Spontaneous bacterial peritonitis is an infection of the acidic fluid without an intra-abdominal surgically treatable source. Intestinal bacterial overgrowth. Ascites promotes intestinal status, decreased IgA, and its diminished activity in the reticular endothelial system, which clears our gram-negatives, and you can have translocation. Remember, it's the polymorphonuclear leukocytes, PMNs, at least greater than 250. After a primary episode of SBP, the recurrence rate at 1 year is approximately 70%, with a 1 year overall survival of 30 to 50%. See, these people are not doing well among persons who do not receive antibiotic prophylaxis. So you have a high risk of reoccurrence, and you have poor survival unless you get antibiotics. Secondary antibiotic prophylaxis in persons who have cirrhosis, who had a prior history of SBP, reduces the risk of SBP from 68% or to 70% to 20%. Most experts recommend daily long-term antimicrobial prophylaxis for patients who have a history of 1 or more episodes of SBP. So what's the other reasons we can have infection with infected mesenteric lymph nodes? Bacteremia leads to infected filtrates from the Gleason capsules of the liver, leads to bacterial ascites, impaired neutrophil function in patients with cirrhosis. Continued discussion of spontaneous bacterial peritonitis, more common with large ascites in acidic fluid, protein less than 1 gram. Remember, in cirrhosis, they're going to have low acidic fluid protein. Most commonly, E. coli is about 70% recurrence. Neutrophil count greater than 250 PMNs, and should check a gram stain. Acidic fluid culture is positive in less than 50%. Blood cultures treatment, cefotaximine or any other third generation cephalosporin plus an IV albumin infusion, 1.5 milligrams per kilogram at diagnosis and 1 gram a kilogram on day 3. You can also consider for prophylaxis for life with Cipro 500 milligrams per day. Also, you can consider trimethoprim sulfametazole. So here's an important thing is that a lot of people will give FFP prior to paracentesis in checking INRs. There's been some large studies that show this is not helpful and it can cause harm. So there's a study they did 1,100 large volume paracentesis, and these patients had low platelets. They had an INR greater than 8 with no significant bleeding events. FFP both has albumin and FFP has pro-clotting factors and anti-clotting factors, and you can actually cause clotting in these patients. Cirrhosis is complicated by a balance of pro and anti-clotting factors. INR does not fully capture and tell the story in cirrhotic patients of their bleeding risk. So the recommendation is to not get FFPs, to not give FFPs prior to paracentesis or checking INRs. Okay, now let's talk about hyponatremia and cirrhosis. Its decreased vasodilation in the periphery leads to decreased blood flow to the kidneys, okay? So decreased vasodilation in the periphery leads to decreased blood flow to the kidneys. The renin-angiotensin-aldosterone system gets activated, leads to salt and water retention. When you have new onset ascites, it shows increased hypotension in the portal venous system. It needs to be evaluated. So you do your TAP, you get your LFTs, your renal function studies, your serum and urine electrolytes, CT scan, or right upper quadrant ultrasound to rule out portal vein thrombosis. When you do a paracentesis, here again, the guidelines do not support giving platelets or FFP. You can get volume overload from giving the FFP. Platelets are dirty, they're stored at room temperature, and you have a risk for infection. So remember, you're gonna have decreased vasodilation in the peripheral system, leads to decreased blood flow to the kidneys. So it activates the renin-angiotensin system, which leads to salt and water retention. You need to rule out SBP, that's where you do the tap. Management sodium and fluid levels, you need to restrict the fluid and restrict the sodium. RAS is your main target. Stirling equation. All this is based off the Stirling equation, which it gives the net fluid movement across the capillary wall. Imagine this is another great giant that we rest on their shoulders, is Ernest Stirling, born in 1896. He started medical school at age 16. Amazing. Think of it as a war between the hydrostatic pressures, which are pushing the fluid out. That's the blood pressure. And the oncotic pressures, that's the pulling the fluid in the proteins. And then we have a filtration coefficient, is how easy the fluid moves across the capillary wall. This is the simple. Hydrostatic pressures pushing the fluid out, and then we subtract the oncotic pressures, we're trying to pull the fluid in, and the filtration coefficient is how easy the fluid moves across the capillary membrane. Just thinking about it is why is this important in this section of cirrhosis, is because they're going to produce less proteins. Remember, cirrhosis is protein poor, and they're going to produce less proteins, and to keep that fluid in, so then you're going to have fluid outside in the extravascular space, because it's not going to be able to remain in the intravascular. This is another image right here. This is an image of a liver with metastatic disease. Right here, see these right here inside the liver. The liver is one of the most common sites for metastasis, nearly 25% of all cases. Colorectal adenocarcinomas are the most prominent. So nearly 20 to 25% of patients who develop colorectal cancer will develop liver metastasis. Other sources can be from breast and prostate cancer or pancreatic cancer. All right, now let's talk about a 32-year-old male with no past medical history, noted for fatigue, abdominal pain, tremors, yellowing of the skin, swelling of the hands and feet, changes in personality. This is a more difficult one. So this is the clinical vignette, and then let's go to the question. This is the unfair board review question, and what findings are most specific for the diagnosis of Wilson's disease. So this patient has Wilson's disease. Going back here again one more time. No past medical history, fatigue, abdominal pain, tremors, yellowing of the skin, swelling of his hands, feet, changes in personality. This is a 32-year-old male who presents with progressive jaundice, tremor, and behavioral challenges. Physical exam reveals mild hepatomegaly and a brownish ring in the corneal margin on slit lamp examination. All right, so they gave you the answer right there. Is the laboratory studies show elevated transaminase, so we know he has Wilson's disease, low serum ceruloplasmin, and increased 24-hour urine copper excretion. Which of the findings most specific for diagnosis of Wilson's disease? Low serum ceruloplasmin, elevated transaminase. Well, we can take that out because a lot of things can cause elevated transaminase. Was the most specific finding, that's what we're looking for. Kaiser-Fleischer rings, which we talk about, those are the brown rings, and increased 24-hour urine copper output, or hepatic copper content greater than 250 dry weight on liver biopsy. Well, the liver biopsy is going to be the most specific. This is most specific. Now, are we going to do this one? Probably not, because no one in their right mind is probably going to do a liver biopsy at that time. If this patient is that sick at that time, liver biopsies themselves can be dangerous. You may get somebody to do it, but this is going to be the most specific, most specific. Here we go. The answer is going to be hepatic copper content. So what we're looking at, low ceruloplasmin and Kaiser-Fleischer rings, or the brown rings, are suggestive, but they're not universally present. The liver biopsy is going to be the most specific. This is what the question is asking. Now, is that what we want to do, or what we're going to do as a liver biopsy? Probably not. Probably not. But this is what the question is. That's where we have to learn on doing board questions. It's not what we want or what they think they want, is what they want is what they're going to get, right? What they want is what we need to give them. What is the most specific for the diagnosis of Wilson's disease? Remember, get away from the sense of justice in that you're want to have social justice or you want to have worldwide justice. Those are great at home. They're not great in board reviews. Board reviews, you want the specific thing they're asking. Is it fair? No. Get over it. Let's talk about Wilson's disease. They can have psychiatric problems and liver disease, hepatic encephalopathy, hemolytic anemia, low alkaline phos, and unconjugated hyperbilirubinemia. It's a rare disorder of copper excretion, usually affects patients younger than 40 years of age. It's autosomal recessive. Can be a mutation in ATP7B gene. Can cause hemolytic anemia when the release of copper from liver cells. Kaiser-Fisher rings on a slit lamp examination. Can have low or normal serum alkaline phosphate levels. Low or low normal serotonin levels. So remember, it's not the most specific. And urine copper is going to be greater than 250 units per hour, 24 hours. So you're going to have high urine copper output. So it's a disorder of copper excretion, usually affecting patients 40 or younger. All right, let's talk about Wilson's disease. The treatment, creatine or penicillamine. Creatine is preferred because of less side effects. They're both chelating agents. Copper is beneficial because it decreases copper intestinal absorption. We talked about this in the patient who had abused the use of his adherent denture cream. These are both chelating agents. Tretinoin, the side effects can be iron deficiency, can get an SLE, drug-induced SLE, muscle spasm, rhabdomyolysis, can have myasthenia gravis. Penicillamine. Now let's talk about this case. This case is a little bit unusual, but it's important. Is that this is a 54-year-old female with past medical history of hyperlipidemia that arrives to the hospital confused. This lady never drank alcohol, and she took no drugs, took only one medication for hyperlipidemia. We can imagine what that is because this is going to be first line for hyperlipidemia. She took a statin. And she had statin-induced liver disease. Is this rare? Yes. So from this liver disease, she developed cirrhosis. From this cirrhosis, she had hyperammonia levels. So she had hepatic encephalopathy, okay? This is induced from the cirrhosis. And you're going, why are we getting a rare case? These are only about 2 cases per million patient years of using these medications. They're safe medications. And LFTs used to be checked regularly when given statins, but the FDA now does not recommend that. So why am I giving this to you is so that you can think about patients, not only do well on boards, but think about patients and get your mind of just, are they taking alcohol, and kind of breaking that from your mindset and think how patients can be harmed. So what happened is this patient came in, she was so altered she had to be intubated with no medications, and she had to sit on the ventilator until we can give her enough lactulose and rifaximin to clear this hyperammonia levels from her. Now let's talk about liver disease. We're going to go with fatty liver definitions. There's been a lot of changes on these. I'm going to give you the old, the recently old, and then the new ones. And the reason why we're doing this is because these still will be floating for you in your discussions with other providers. They'll still be on literature that you see. The new definitions are going to start popping up in testing, but that takes time. So you need to have all those. Unfortunately, you have to have all these different data, pieces of data, so that way you can communicate properly with both your patients, other providers, and reviewing of literature. Fatty liver definitions. Hepatic steatosis is fatty liver. Remember, this is the old ones. Non-alcoholic fatty liver disease, NAFLD, this has gone away. This is an umbrella term for hepatic steatosis associated with metabolic syndrome. I'm teaching you this because you're going to still have people talk to you about these. Metabolic associated fatty liver disease, MAFLD, proposed new name is NAFLD, and we'll keep going on these because there's a whole bunch of proposals, a whole bunch of changes. Non-alcoholic steatohepatitis is NASH, with inflammation of the liver associated with NAFLD. NAFLD is the big umbrella. And cryptogenic cirrhosis, meaning we don't know why. Cirrhosis of unknown etiology. On our young lady is that who unfortunately took a statin, we were able to figure this out. We're figuring this out. Hers was easier because there was never any alcohol intake in her world. She only took one medication. She only took it for a short period of time and developed this. And this was, she had a very good PCP that was followed up her liver enzymes. They stopped the statin, they thought soon enough, but then she actually had a biopsy that showed these changes. So she was a case study of a very good workup that was done by her PCP. Hepatic steatosis, pathological fatty infiltrated liver. There can be 2 types. Non-alcoholic, this is going away, but I'm keeping it here so that way you can remember and be able to discuss with others, is NAFLD. And then there's alcoholic NASH is going to be 10 to 20% of NAFL development, is inflammation of the liver associated with NAFL. 20 to 40% of these patients will develop fibrosis leading to cirrhosis. This is unfortunate, poor lady. Despite what the reference labs, liver experts state, okay, this is a discussion right here is the liver, people who specialize in, their GI doctors that specialize in the liver, they have a different definition and they use different reference numbers for values than what we normally use. So they're going to use for ALT for being elevated is going to be greater than 25 is their cutoff for females, 33 for males. And this is associated with liver morbidity. That's where they're more specialized and they use these numbers. They use a lower cutoff than we do. Ultrasound for detecting hepatic steatosis. This is not the standard of care, but it can be used. Basically, the sensitivity is 89% and specificity is 81%. And this is because the case against using ultrasound was old, based on old research, okay? We've gotten better at the techniques, and this is comparing MRI to ultrasound, and this is comparing to the standard of care, which is a liver biopsy. Why don't we just biopsy everybody? Because biopsying, we're only getting 1 in 50,000 portions of the liver, and we can do is we can cause harm to the patient. There's many cases, well, 1% of patients who get liver biopsy can have morbidity and mortality. All right, non-alcoholic fatty liver disease is the most common cause of chronic liver disease in Western countries. It's a diagnosis of exclusion. These are patients that do not use alcohol or heavy alcohol use. It can be associated with metabolic syndrome. What is that? Central obesity, diabetes, insulin resistance, hyperlipidemia, hypertension. This is the signs of the apocalypse: central obesity, diabetes mellitus, insulin resistance, hyperlipidemia, and hypertension. This is what's killing off more Americans than any foreign war ever will, because we are not taking care of ourselves, we're not eating right, and we're not exercising enough. And we're eating the wrong foods and massive quantities of the wrong foods. Hepatic steatosis can be noted on imaging or biopsy. This can be also, and then the ultimate test would be is getting a biopsy.